You know that feeling? Maybe you've seen it with an older relative or heard stories. Someone starts forgetting things more often,
Yeah.
or their personality just seems different. It can be really unsettling.
It really can. And figuring out what's going on, especially when things change suddenly, it's tough for everyone involved.
Well, you're definitely in the right place if you want to understand more. Welcome to the deep dive. Today, we're tackling a really significant topic: how dementia is assessed, particularly in the emergency department, the ED.
Yeah, we're drawing from a resource called RCA Learning. It's actually aimed at emergency doctors.
But don't worry, our goal isn't to make you an expert diagnostician. We're here to sort of cut through the medical jargon.
Exactly. We want to give you the key insights, the must-knows about dementia.
So you'll come away with a much clearer picture of what it is, the different kinds, how it affects people.
The challenges in spotting it, especially when things reach a crisis point, and, what can actually be done to help manage it.
Ready to jump in?
Let's do it. It's such a critical area. And that source, it really starts by defining dementia clearly. It calls it a progressive illness that impairs mental function.
Progressive being the key word there, I suppose, not sudden.
Generally, yes. And the sheer scale. I mean, the numbers are quite stark. We're looking at around 180,000 new cases diagnosed each year just in England and Wales.
Wow, 180,000.
Wow.
That's a lot of families facing this every year.
It really puts it into perspective, doesn't it? It's not just a medical issue. It's a huge societal one.
And it's not just memory loss, is it? The source mentions other areas get affected too.
Oh, definitely. That's crucial. It hits multiple areas. Memory, yes, but also language, sense of orientation, behavior, attention span.
Visual spatial skills, what does that mean exactly?
Things like judging distances, recognizing objects or faces, navigating familiar spaces. Also, executive functions, planning, organizing, problem solving. Even motor control can be affected eventually.
Right. Which explains why it becomes so important as people get older, especially if they end up in the ED for some reason.
Precisely. They might come in because of a fall or confusion directly related to their dementia, maybe dementia that hasn't even been diagnosed yet.
Or it could be an underlying issue, making some other health problem worse.
Exactly. Their needs become really complex. And that puts a huge strain not just on healthcare services, but deeply on the carers too. It can really impact the patient's independence and the carer's own well-being.
So understanding this isn't just for doctors, it sounds like it's pretty vital for, well, anyone. Knowing the types, the progression, the treatments, it helps support everyone involved, doesn't it?
Absolutely. It's all about enabling better, more patient-focused care.
Okay, so let's get a bit more specific then. You mentioned types. The source breaks it down into four main categories, right? Based on sort of different patterns and what's happening in the brain.
That's right. We have Alzheimer's disease, probably the most well-known. Then vascular dementia, dementia with Lewy bodies, and frontotemporal dementia.
And getting a definitive diagnosis, that's tricky while someone's alive.
Very tricky. The source points out that a definite diagnosis usually requires looking at brain tissue after death through autopsy or biopsy.
So in practice, doctors work with probable or possible diagnoses based on symptoms and clinical criteria.
Exactly. And often people have features of more than one type that's called mixed dementia.
Ah, okay. So if it's mixed, how do they decide on treatment?
Generally, they'll treat based on whichever type seems to be the most dominant, the one causing the most prominent symptoms.
Got it. So let's maybe peel back another layer. What's actually going wrong in the brain? Let's talk risk factors first. The source lists quite a few.
It does. Age is the biggest one, obviously. Then female gender, drinking too much alcohol, significant head injuries, ones causing loss of consciousness.
Also depression, learning difficulties, and some familiar lifestyle factors.
Yes, things like diabetes, obesity, high blood pressure, high cholesterol, and smoking. The usual suspects for other health issues, too.
But here's something interesting the source mentioned. Just tackling those lifestyle factors individually, the modifiable ones, it hasn't actually been proven to reduce overall dementia rates.
Yeah, that's a really nuanced point. It's not saying don't be healthy, obviously, but the evidence, according to this source, isn't quite there to say reducing individual factors definitively stops dementia developing across the population. It's complex.
That is surprising. So how do these factors, or maybe just the disease process itself, cause the damage? The source talks about specific features, right? Like tangles and plaques.
Exactly. Think of Alzheimer's. Inside the brain cells, you get these things called neurofibrillary tangles. They're clumps of a protein called tau, basically gumming up the works from the inside, causing the neuron to fail and die.
And the plaques?
They're outside the cells.
Yeah.
Amyloid plaques, deposits of beta amyloid protein. They disrupt communication between cells. And interestingly, the source notes a link between head injury and increased amyloid levels in the fluid around the brain.
So tangles inside, plaques outside. And this leads to connections being lost.
Precisely. It's called synaptic loss. Fewer connections mean neurons die off, leading to widespread brain shrinkage or atrophy.
And then there are Lewy bodies. What are they?
They're different. Lewy bodies are abnormal clumps of protein inside the cytoplasm of the neuron, disrupting its function. They're strongly linked to Parkinson's disease as well, which explains the overlap in symptoms sometimes.
Okay. And the last one was cerebrovascular disease, linked to strokes.
Right. This ties back to those risk factors like hypertension and diabetes. Damage to blood vessels in the brain, like small strokes or reduced blood flow, can lead to vascular dementia.
Okay, that gives us a clearer picture of the what and why. Now, how does each type actually look? How do they present? Remembering, as you said, that mixed patterns are common.
Good point. Let's start with probable Alzheimer's disease, AD. It's the most common. The key is that gradual progressive decline.
So initially just maybe a bit more forgetful.
Yeah, forgetfulness that gets worse over time. They may be getting lost in places they know well, struggling with hobbies they used to enjoy, like cooking or cards, repeating questions.
And neglecting personal care, maybe difficulty with decisions.
Yes, all of those. And in the later, more severe stages, they might not recognize close family members. And speech can really break down. Memory impairment is the absolute hallmark.
What would suggest it isn't Alzheimer's? Any red flags?
Definitely. The source mentions sudden worsening of function, specific neurological signs like weakness on one side, seizures, or significant changes in how someone walks early on. Those things make typical AD less likely.
Okay. How about probable vascular dementia, VD, then? You said it's more abrupt.
Yes, often it has a stepwise pattern, so cognitive decline and memory loss impacting daily life, plus evidence of cerebrovascular disease like signs of a stroke on examination or on a brain scan.
And a clear link in time, like symptoms starting soon after a stroke.
Exactly, usually within about 3 months. Or the decline happens in clear steps, sudden deteriorations, rather than a smooth downhill course. Mood swings and behavioral changes like aggression are also pretty common here.
So that stepwise pattern is a key difference from AD's gradual decline.
It really is.
Next up, probable dementia with Lewy bodies, DLB. This sounds quite different again.
It is. You still get progressive cognitive decline, but the standout features are often in attention, planning skills, and visual perception. Plus, you need 2 out of 3 core features.
Okay, what are those?
1. Fluctuating cognition, meaning big swings in attention and alertness, sometimes day to day or even hour to hour. They might seem fine one moment and very confused the next, or have periods of excessive drowsiness.
2.
Recurrent visual hallucinations, often quite detailed and well-formed, seeing people or animals that aren't there.
And 3.
Spontaneous motor features of Parkinsonism. Things like tremors, stiffness, slow movement, shuffling walk appearing early in the illness, unlike in AD where they might come much later, if at all.
So those fluctuations, hallucinations, and Parkinson's-like symptoms are key for DLB.
They really are the classic triad, though other things like repeated falls, fainting, or sensitivity to certain antipsychotic medications can also occur.
Fascinatingly complex. Okay, the last main type. Probable frontotemporal dementia, FTD. How does this one typically show up?
FTD is often striking because the first things to change are usually personality, behavior, or language, rather than memory.
So memory might be relatively okay initially.
It often is, yes. You see this gradual decline, but it manifests early on as changes in social conduct. Someone might become impulsive, say inappropriate things, lose empathy, become disinhibited.
Like maybe shoplifting or other out-of-character actions.
Exactly. Or they might develop apathy, lose motivation. Repetitive or compulsive behaviors can also emerge. Often they have very little insight into these changes.
And the language aspect.
Language problems are also common early on, particularly with expressing themselves. Finding words, forming sentences, reading and writing can become difficult, although understanding often stays intact longer. In severe cases, people can become mute.
So FTD is really marked by those early behavioral and communication changes.
That's a key takeaway, definitely.
Right, we've covered the types. Now let's shift to the pointy end, if you like. Assessment and diagnosis, specifically in the ED. You mentioned it's often the first stop.
It often is, yeah. Perhaps because of a sudden worsening of behavior, confusion after a fall, or just carers reaching a crisis point.
But diagnosing dementia properly in a busy, noisy ED, That sounds incredibly challenging.
It absolutely is. You've got time pressure, limited history maybe, and the big challenge of sorting out dementia from delirium, that acute confusion or even depression. They
Hmm.
can all coexist too, which makes it even harder.
Getting the story straight must be difficult if the patient themselves is confused or can't communicate well.
Exactly. That's why the source really emphasizes getting a collaborative history. Talking to family, carers, they are often the main source of information.
What key things do doctors need to ask about?
You need to know about the current symptoms, obviously, but crucially, the pattern of decline, how fast, gradual, or stepwise. What specific abilities are impaired? Are there other symptoms like hallucinations, delusions, low mood?
And their background, medical history, medications.
Yes, past medical history, especially things like strokes or Parkinson's, any risk actors, a full drug history, including alcohol, and really importantly, the social situation. How are they coping at home? How is the carer managing?
This history helps distinguish those 3Ds you mentioned, dementia, delirium, depression.
It's critical for that. Remember the key differences. Onset, delirium is fast, dementia slow. Pattern, delirium fluctuates wildly, dementia progresses. Alertness, often impaired in delirium, usually normal in dementia depression. And of course, delirium depression, often reversible, dementia isn't. Getting that right guides the next steps.
Okay, so after the history, there's a physical examination.
Absolutely. It's essential to look for reversible causes for the current problem, like an infection, an injury from a fall. It can also reveal signs of neglect or difficulties with self-care, and sometimes provides clues to the dementia subtype, like Parkinsonian signs in DLB.
What about specific cognitive tests, like the ones where they ask you the date or to remember words?
Yes, cognitive assessments are important. Things like the Mini Mental State Exam, MSE, or the Six-Item Cognitive Impairment Test, 6CIT. They test attention, memory, executive function. They aren't perfect diagnostic tools on their own, especially in the ED.
Why not perfect?
Well, scores can be affected by things like someone's prior education level or if English isn't their first language. Many tests require reading and writing skills, but they can provide a baseline and help track changes over time if repeated later.
Are there any simpler ones?
The source mentions a couple. The GPC-OG is designed for GPs, the 7-minute screen, and the Test Your Memory, TYM test, which is interesting because the patient can largely fill it out themselves. And the 6CIT is useful as it doesn't rely on reading or writing.
Right. And investigations like blood tests or scans. What's the main goal there in the ED?
The main goal in the initial phase is to find and treat any reversible problems that could be causing or worsening the confusion.
So things like infections, electrolyte imbalances.
Exactly. Standard blood tests checking blood count, kidney function, liver function, electrolytes, calcium, glucose, thyroid function, vitamin B12, and folate levels. A urine test for infection is also standard.
What about things like chest x-rays or brain scans?
They aren't routine unless there's a specific reason to suspect something like pneumonia for a chest x-ray or a bleed or tumor in the brain for a scan. Neuroimaging is usually done later, electively, as part of a specialist workup, unless there's an urgent concern.
Okay, so assuming other causes are ruled out and dementia is suspected or confirmed, what about management and support? What's the general approach?
The philosophy is very much patient-centered and multidisciplinary, using both medication pharmacological strategies and non-drug approaches to minimize distress and help patients and carers maintain quality of life and activity levels.
Let's talk medication first. Are there drugs that specifically treat dementia?
For moderate Alzheimer's disease, yes. There are drugs called acetylcholinesterase inhibitors, names like donepezil, galantamine, rivastigmine, but there are strict rules around prescribing them.
Like needing a specialist diagnosis?
Yes, usually started by a specialist, often linked to scores on tests like the MMSE, reviewed regularly, and the carer's view is also considered. Importantly, the source states these drugs are not helpful for vascular dementia, DLB, or FTD.
What about other medications for behavior?
Antidepressants or antipsychotics might be used for severe behavioral or psychological symptoms, but very cautiously. The source highlights they come with an increased risk of serious side effects, including death, so they're usually a last resort when symptoms are severe and causing significant distress or risk.
And in that acute ED situation, if someone is agitated and potentially unsafe?
If someone poses an immediate danger to themselves or others, sedative medication like lorazepam or sometimes haloperidol might be necessary, usually given by injection, lowest effective dose, trying to use just one drug if possible. And it's crucial to talk about why this happened with the patient and family later on.
Okay, moving away from drugs, what about non-pharmacological help?
There's quite a lot, actually. For cognitive benefits in mild to moderate dementia, structured group stimulation programs doing exercises that work the brain can be helpful.
And for behavioral issues.
Things like aromatherapy, massage, multisensory stimulation rooms, music therapy, dance therapy, even animal-assisted therapy. These can all help reduce agitation and improve well-being.
That sounds much more holistic. And beyond direct interventions, what about general support?
Support is absolutely key. An early diagnosis helps enormously because it allows time for planning and accessing help.
What kind of help?
Practical and emotional support for both the patient and the carer. Information is vital, understanding the symptoms, how the disease might progress, treatment options, but also things like financial benefits and legal advice, like setting up power of attorney.
Are there specific places people can go?
Yes, the source mentions specific groups like the Lewy Body Dementia Association or the Association for Frontotemporal Dementias, and broader organizations like the Alzheimer's Society, NHS Choice's website, Carers UK, Citizens Advice Bureau. The key is often needing someone else to proactively seek this help, as the person with dementia might not be able to.
That leads us nicely to the key takeaways. What happens if we fail to spot dementia early?
The consequences can be significant, according to the source. It might mean reversible causes of confusion aren't investigated properly, specialist assessment gets delayed, and crucially, those helpful treatments, both drug and non-drug, aren't started when they could be most beneficial.
And the delay impacts planning too, right?
Absolutely. You miss that window where the patient might still have the capacity to make important legal and financial decisions. Plus, there's less vigilance about critical safety issues like fitness to drive or managing safely at work if they're still employed.
So the bottom line is awareness.
Awareness is key. Raising awareness among families, carers, healthcare professionals, especially in emergency settings, about the features of dementia and its implications. That's really the core message.
Wow, okay. We have covered a lot of ground today, from the very basics of what dementia is and just how many people it affects.
Through the four main types: Alzheimer's, vascular, Lewy body, and frontotemporal.
Looking at the science underneath, the tangles, plaques, Lewy bodies.
And how each type tends to show up differently in terms of symptoms.
Then we really dug into the challenges of assessment, particularly in the ED, differentiating the 3Ds.
The role of history, examination, cognitive tests, and investigations.
And finally, the management balancing medications, non-drug therapies, and that crucial layer of support for everyone involved.
It's a really comprehensive picture.
Definitely. This deep dive, hopefully, has given you a much richer understanding of this complex condition. And like we said, this isn't just info for doctors. It's relevant for anyone whose life might be touched by dementia, directly or indirectly. It helps us all be a more informed, more compassionate community.
Well said.
So, thinking about everything we've discussed, the different phases of dementia, the importance of early intervention and support, here's a final thought to leave you with. Given how widespread dementia is becoming, what new questions does this raise for you about how we as communities, and maybe even you personally, can better prepare for and support those living with dementia and their families?